Hello students, today's topic is bronchial asthma or pharmacotherapy of bronchial asthma. Okay, it is a one kind of respiratory disorder, and the other kind of respiratory disorder are COPD, means emphysema and bronchitis. But in the slides or in this session, I would like to discuss about only bronchial asthma, what is bronchial asthma, and its pharmacotherapeutic effect, okay, or pharmacotherapeutic approaches. Okay, so what is bronchial asthma? Basically, asthma is a common disorder, okay, common disorder, and which is characterized by airway inflammations and hyper responsiveness to stimuli that produce bronchoconstriction. Means there are lots of stimuli are there which bronchoconstrictions. How? Now, by the means of airway inflammation. And this stimuli includes hot air, exercise, a wide variety of allergens, emotional stress, etc., etc., etc. Okay. So, what is asthma? Now, asthma is a one kind of common disorder, and it is characterized by airway inflammations and hyper-responsiveness to stimuli that produce bronchoconstriction. Okay, and these stimulants include cold air, exercise, wide variety of allergen, and emotional stress. If we're talking about the classification of asthma, then it will two types. Uh, First one is the extrinsic asthma, which is mostly episodic, less prone to status asthmaticus, and another one is the intrinsic asthma. It tends to be perennial status asthmaticus is more common. Basically, most episodic asthmatic attack, if we told about, then it is extrinsic asthma, and it is common in all kind of developing country as well as developed country like USA, where death are accounted. If you are talking about the number of accounting deaths, then 5,000 in year, and which is a big count near a developed country. Okay. And if you're talking about the pathophysiology of asthma, then we should take a look the picture, and as well as its associated dynamic uh, representation, that a susceptible person which uh, which are exposed towards the some environmental factors like emotional stress, like exercise, like or other environmental factor like smoke, like pollen grains, etc., etc. Then stimulus trigger happens. When stimulus trigger happens, which it leads to the release of variety of substance like histamine, adenosine, bradykinin, or major basic proteins. Basically, they are inflammatory substance which are released from the muscle. It may be eosinophils, it may be basophils, it may be neutrophils, or from macrophages also. Okay. Then this kind of substance, basically, these are the asthmatic stimuli, which the response to asthmatic stimuli, their releases lipid mediator derived from arachidonic acid, such as leukotriene and prostaglandin. As we know, the leukotriene and prostaglandin, they are potent they are potent smooth muscle contractant. They basically they inflame the airway, edema or discoloration of the bronchial epithelium cell, as well as hypertrophy of bronchial smooth muscle, which leads to narrowing of the airway passage, and obstruction also occurred. And this phenomenon, or this kind of uh, you should tell this kind of phenomena which is associated with a narrow of air passage or airway obstruction is called as the asthma. Okay, so these are the basic pathophysiological mechanism of asthma. Okay, as we see in the picture. Okay, these are the allergen, basically allergen, which are basically asthmatic stimuli, which is called as the asthmatic stimuli, which leads to the release of some kind of mediators, like even some kind of inflammatory mediator like histamine, like adenosine, like bradykinin from the mast cell, eosinophil, basophil, etc., etc., which leads to production of the arachidonic acid, such as leukotriene, prostaglandin, and which cause of edema of the airway, or where obstruction of the airway passage is happened and asthma is occurred. Okay. So based on this pathophysiology, what are the treatment approaches? If you're talking about the treatment approaches, if you're talking about the treatment approaches, then what are the treatment approaches we should adopt if we reviewing the pathophysiological or pathophysiology of the bronchial asthma? Then we should consider, first point is the we should consider the prevention of antigen antibody reactions, which is occurs on the mast cell, uh, which occurs on the mast cell, like avoidance of the antigen hyposensitizations. Second one is the neutralization of Ig, such as omalizumab. Third one is the suppression of the inflammation or bronchial hyperactivity like corticosteroid. Fourth one is the prevention of the release of mediator like muscle stabilizer. Fifth one is the antagonism of release of the mediator like leukotriene antagonist, antihistaminics, platelet activating factors, that is the PAP antagonist, etc., etc. If we black up the constrictor neurotransmitter, means if we black the constrictor neurotransmitter like sympathomimetics, we can use the directly acting bronchodilators like methylxanthines. Okay, so these are the treatment, basically treatment approaches of the bronchial asthma. The first one is the prevention of the antigen antibody reactions, that is the avoidance of the antigen, obviously hyposensitization. Second one is the neutralization of the Ig, that is the omalizumab. Third one is the suppression of the uh, inflammation and bronchial hyperactivity, that is the corticosteroid. Fourth one is the prevention of release of mediator like a muscle stabilizer. Fifth one is the antagonism of release mediator, that is the leukotriene antagonist, antihistamines, PAP, etc., etc. Fifth one is the black of the constrictor neurotransmitter, that is the sympathomimetics. Sixth one is the directly acting bronchodilators, that is the methylxanthine. Okay, so based on this treatment of approaches, we have classified some anti-asthmatic drugs. Like first one is the bronchodilators. This is the first one or first line choice of the drug. First line choice of the drug. In the case of bronchial asthma, that is the bronchodilators, and bronchodilators are further classified as beta sympathomimetics. Example is the salbutamol, terbutaline, salmeterol, formoterol, ephedrine, etc., etc. Methylxanthines derivatives are also bronchodilators. Example is the theophylline, aminophylline, choline theophylline, hydroxythiopyline, etc., etc. Another bronchodilators are the anticholinergic drugs like muscarinic receptor antagonist, especially muscarinic receptor antagonist we are talking about, and the example is the ipratropium bromide and tiotropium bromide. Second class is the nicotine antagonist, that is the LTE for antagonist. Example is the montelukast, japilukast. Third one is the mast cell stabilizer, sodium chromoglycate, ketofen, etc. Fifth one is the corticosteroid. Here is the systemic corticosteroids are there, like hydrocortisone, and inhalation steroid are there. That is the beclomethasone dipropionate, budesonide, flutoconazole propionate, fluonicin, sisconoids, etc., etc. Anti-IG antibody are there, like omalizumab. So, firstly, I would like to elaborate the bronchodilators first. Okay, basically, bronchodilators. The first example is the beta agonist, which beta agonist stimulates the beta adrenergic receptor bronchi, especially which leads to smooth muscle relaxation. Okay, anti-cholinergic drugs is also a beta bronchodilators, which reduce the vagus tones of the vagus. Vagus means that is the ninth cranial nerve or eighth cranial nerve. That is the ninth cranial nerve, and which leads to smooth muscle relaxation. And methylxanthine, that is the basically PDE5 inhibitor, means phosphodiesterase 5 inhibitor, and they are known as a long-term prevent, that is the bronchoconstriction. Okay. So if we're talking about the sympathomimetics, means beta 2 agonist. The selective beta 2 agonist is the primary bronchodilator used in the treatment of the asthma or acute asthmatic attack. Beta 2 adrenergic receptor agonist stimulate the beta receptors, whereas increasing the CMP concentration is smooth muscle are there and causing bronchodilations, and also increase the conductance of the large calcium ions or sensitive K plus channels in airway smooth muscle, leading to membrane hyperpolarization and relaxation. Okay. So what is this? Now, beta 2 adrenergic receptor basically stimulate beta receptor because they act on the beta receptor, increasing the CMP concentration. And if we look back the some earlier session about G protein coupled receptor, then you should understand the importance of the fundamental of the different kinds of receptor, which is associated all kind of drugs mechanistic approach. If we clear about this concept, then it is easy to understand this kind of mechanism of these drugs also. Okay. So basically, beta 2 adrenergic receptor agonist stimulate beta receptor, which increase the CMP concentration. It also increases the conductance of the large calcium and potassium channels in the airway smooth muscle, which is leads to the hyperpolarizations, and hyperpolarizations means the muscle relaxation. And the selective beta 2 agonist basically relax the bronchial smooth muscle without affecting cardiac function. In higher dose of selective beta 2 agonist, increasing the heart rate by stimulating the cardiac beta 1 receptor. And thus, selective beta 2 agonist produce hypertension to patient, those having digitalis. Types: long-acting beta 2 adrenergic receptor agonist and short-acting beta 2 adrenergic receptor agonist. Okay. If we're talking about the salbutamol specially, this is the one kind of selective beta 2 agonist with less cardiac side effects. Inhaled salbutamol produce bronchodilation within 5 minutes and action lasts for 2 to 4 hours, basically, which is good. And used for acute asthmatic attack, not suitable for prophylaxis. And its side effect is palpitation, restlessness, nervousness, throat irritation, and ankle edema also. If we're talking about the metabolism and the metabolized in gut, and oral viability is 50% is there. Duration of action, that is the oral salbutamol acts 4 to 6 hours, and whereas dose is the 2 to 4 mg oral and 0.25 to 5 mg for IP. And in case of SC injection, there is 200 to 200 g per inhalation. And if we're talking about the terbutaline, then uh, you can uh, you can tell about the similar to salbutamol also. Regular use of dose not reduce bronchial hyperactivity, and its dose basically 5 mg its oral dose and 0.25 mg is IP dose. But if you're talking about the subcutaneous dose, that is the 250 microgram per inhalation. Okay. And what about bambuterol? That is the bicarbonate ester basically of product terbutaline, slowly hydrolyzed in plasma and lung by pseudocholinesterase to release the active drug over 24 hours. It also reversely inhibits the pseudocholinesterase in dose-dependent manner, used in chronic bronchial asthma in single everything dose 10 to 20 mg per hour. In the case of salmeterol, fast long and selective beta 2 agonist with slow onset of action, and twice daily for maintain the therapy and nocturnal asthma, but not acute asthma. Concurrent use of inhaled glucocorticoid with salmeterol is advised for patients with persistent asthma. If you're talking about the COPD patient, then equivalent to inhaled anticholinergic in COPD reduce the breathlessness by abolishing the reversible component by your obstruction. Okay. If we told about the formoterol, there is a long-acting selective beta 2 agonist which act 12 hours when inhaled, and it is compared to salmeterol, and it has faster onset of action actually. Okay. Then the second kind of drug is the methylxanthine, and theophylline is the example of that. Theophylline and its derivative are mostly commonly used for the treatment of the COPD and asthma. Caffeine, theophylline, and theobromine are naturally occurring xanthine alkaloids, which have quantitatively similar of actions. And if we're talking about the mechanistic approach or mechanism of action, then methylxanthine inhibits cyclic nucleotide phosphodiesterase, that is the PDES, and thereby preventing the conversion of CMP and CGMP to 5MP and 5MP. Okay, 5GMP, sorry. And respectively, uh, inhibition of PDES will lead to an accumulation of intercellular CMP and CGMP. Here, bronchodilation, cardiac stimulation, vasodilation occurs when CMP level rises in the constant cell. Theophylline and related methylxanthines are relatively non-selective in the PD subtypes inhibitor. Actually, theophylline is a competitive antagonist at adenosine receptors, and adenosine can cause bronchoconstriction in asthmatic and potentiate immunologically induced mediator release from human lung cell. And methylxanthine inhibits the adenosine action, thereby causing bronchodilations. Here, the mechanistic approach of the methylxanthine, which cause bronchodilations by uh, inhibit the PDE5, basically PDE phosphodiesterase enzyme, and which leads to CMP formation, and and CMP formation. If CMP formations happen, and then we see that bronchial tones changes in the bronchial tones, and as well as the bronchial smooth muscle bronchial relaxations are there, and uh, which is act as a therapy corner of bronchial asthma. Okay. If we're talking about the pharmacological actions of the methyl and xanthine on the CNS, they have the stimulant and affect higher center. Caffeine 150 to 200 mg produces a sense of well-being, alertness, beats boredom, alleviates fatigue to improve performance and increase the motor activity. And caffeine is more active than theophylline in product these effects. Higher dose cause nervousness, restlessness, panic, insomnia, excitements. Still higher dose cause tremors, delirium, and convulsion also. Theophylline is more toxic than caffeine. There's, as we know, theophylline have narrow therapeutic window and stimulate medullary, vagal, respiratory, and vasomotor centers. High dose of theophylline cause or methylxanthine cause vomiting, gastric irritation, and stimulation. On the CBS, it stimulates the heart and increase the force of contractions as well as increase the heart rate, but decrease in vagal stimulation and negative variable, which cause tachycardia, increased cardiac output, and increased cardiac work. Higher dose caused cardiac arrhythmias. Effect on blood, if we're talking about the effect on blood pressure of this kind of drug is variable and unpredictable. Usually, rise in systolic fall and diastolic BP is observed. In case of the smooth muscle, relaxation is there. Theophylline is more potent and slow, sustained dose-related bronchodilation, increased vital capacity also, direct action due to adrenergic stimulation. Biliary spasm is relieved, but the effects of intestine and urinary tract is negligible. Theophylline is more potent and caffeine has minimal actions. If we're talking about the methylxanthine on kidney, mild diuretics are inhibiting tubular reabsorption and sodium and water retention, increasing the vascular flow and glomerulus filtration rate. Theophylline is more potent, caffeine has minimal effect. Skeletal muscle, caffeine enhances the contractile power. In high dose, it increases the release of CA, sarcoplasmic reticle by direct action, etc. etc. So this is the or these are the pharmacological actions of methylxanthine in a single glance. If we're talking about the methylxanthine, especially theophylline, adverse effect of methylxanthine of theophylline. Here, methylxanthine has narrow safety margins or narrow margin safety. Where CBS and CNS stimulants, ADRs not dependent to dose and GI stress are there. Children are more liable to develop CNS toxicity. Rapid IV injection cause precordial plain, synocope, and sudden death. After the bronchodilators and methylxanthines, in the methylxanthine and beta 2 agonist, anticholinergics are there as a bronchodilators. That is the parasympathetic activation and release of ACH cause bronchoconstriction and increase, that is the mucus secretion. That's why anticholinergic drugs are used as a blockage of ACH or acetylcholine, and also reduce the volume of respiratory secretion, less effective than sympathomimetic. Inhaled ibotronium and tiotropium are choice of the bronchodilator, choice in COPD. Adverse drug reaction is the dry mouth, respiratory tract discomfort, etc. etc. Here, the leukotriene antagonist both have the similar action and clinical utility. Block the cis leukotrienes, alternated for inhaled glucocorticoid, prophylactic therapy for mild moderate asthma, not used for terminating asthma. Both are very safe drugs and ADRs are few. That is the headache, rashes, eosinophilia, neuropathy are infrequent. Few cases of Church-Strauss syndrome, basically vasculitis with eosinophilia have been reported. And dose is montelukast 10 mg OD and jafilukast 20 mg BD. This is the mechanistic approach of the leukotriene, which previously discussed. That is the phospholipid from the phospholipid fraction of the membrane. Phospholipase basically are produced, and phospholipase which cause the arachidonic acid production, and basically leukotriene antagonist and arachidonic acid basically produce the leukotrienes LT, and leukotrienic antagonists are the drug which reverse or which block the production of leukotriene from the arachidonic acid by blockage of 5-lipoxygenase basically. And here bronchoconstriction and inflammation is not occurred. Here is the another kind of drug, that is the corticosteroid are not bronchodilator, basically benefit by reduction of bronchial hyperactivity, mucosal edema, and by suppressing various kind of inflammatory reactions. Basically, inhaled glucocorticoid are partially absorbed, and because of their systemic is oral glucocorticoid are usually reversed by patient with severe persistent asthma. Okay. Mast cell stabilizer example is the sodium chromoglycate, ketotifen. They inhibit the granulation of the mast cell by trigger stimuli and prevent the release of histamine, leukotriene, PAF, interleukin, etc. from the mast cell. And inhibition of the mediator released by the chromoline is through a blockade of the calcium influx in mast cell, basically. Long-time therapy reduce the therapeutic responses, and it is not a histamine antagonist, basically. And bronchodilator ineffective in asthmatic attack also. Okay. Use of the mast cell stabilizer in the bronchial asthma, and sodium chromoglycate is used as a long-term prophylactic uh, treatment approach for the patient not adequately controlled by inhaled bronchodilators. Even it is used in allergic rhinitis also. Chromoglycate is not a nasal decontinent. Regular prophylactic use as a nasal spray produce symptomatic improvement in many patients. Okay. It is also used in allergic conjunctivitis also. Okay. Adverse effect of this kind of drugs are bronchospasm, throat irritation, cough, athalgia, rarely nasal congestion is there. And here is the last kind of drug, that is the anti-IgE antibody, that is the omalizumab. That is the recombinant DNA-derived monoclonal antibody, and selectively bind with the human immunoglobulin E and decrease the binding affinity of IgE to the high affinity IgE receptor on the surface of the mast cell and basophils, and which reduces the allergic responses. Okay. This kind of drug may be particularly useful for the treatment to moderate to severe allergic asthma in patients who are poorly controlled to conventional therapy, and due to the high cost of the drug, limitation on dosage, and limited clinical trial data, it is not currently used in first-line therapy also. Okay, I think all of you are understand the topics very well. Okay, thank you. Good day.